Hello and welcome. My name is Dr. Jack West, and I'm a medical oncologist and the founder and CEO of GRACE, the global resource for advancing cancer education. Our program today is made possible through generous support from the Longevity Foundation. This is part of a series of podcasts covering challenging clinical cases in lung cancer that don't have a clear, correct answer for the best treatment based on the evidence, and they therefore require our best judgment as experts consider the options and the merits of one treatment over another. The same series of cases was discussed with multiple experts in the field of lung cancer from several different institutions to provide a better sense of where there is consensus and where there is still a wide range of treatment styles that might all be considered appropriate. Each podcast starts with a brief thumbnail of a case presentation and then discussion from a live program done with Dr. Robert Doble, Assistant Professor of Medical Oncology at the University of Colorado Medical Center in Denver, Colorado, and Dr. Jyothi Patel, Associate Professor of Medical Oncology at the Feinberg School of Medicine at Northwestern University in Chicago, Illinois. The discussions will then continue with commentary by several other clinical experts, including Dr. Suresh Ramalingam from the Winship Cancer Center, Emory University in Atlanta, Georgia, Dr. Jonathan Goldman from Premier Oncology in Santa Monica, California, Dr. Julie Bramer from Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland, Dr. Heather Wakely from Stanford University Cancer Center in Palo Alto, California, and Dr. Karen Reckamp from the City of Hope Cancer Center in Duarte, California.
The first case is a 65-year-old man who undergoes a left lower lobectomy for what appears clinically to be a rather small, about 1.4 centimeter squamous cell carcinoma, a non-small cell lung cancer, based on pathology prior to surgery. However, the pathology after he has completed that surgery shows that in addition to the primary tumor, there is actually a small satellite lesion that is just about 3 millimeters, and it appears to be distinct, separate from the main tumor. So this person comes to see you for consideration of adjuvant therapy and has a good performance status. It's 4 or 5 weeks after the surgery. And the question, and I'll start with Dr. Doble about your thoughts on how enthusiastic or reluctant you might be about adjuvant chemotherapy for someone with an otherwise very small tumor, but with one or more very tiny satellite lesions.
Sure. First of all, I think it would definitely be worth a discussion about the pros and cons of adjuvant chemotherapy in this setting. Technically, under the new staging system, this would be a T3N0 or stage 2B. And under the old staging system where most of the adjuvant trials were run, it would be a T4N0 and technically stage 3B. So if you look at it from that standpoint, there is a role for consideration of adjuvant chemotherapy. And so I believe it would be worth discussing the potential benefits that adjuvant chemotherapy can increase the risk of survival. The absolute benefit is relatively small in stage 2, probably only 5 or 6%. But for someone who was a good performance status and wanted to do everything possible to prevent their cancer from coming back, I think it would be worth a consideration.
And Dr. Patel, how would you approach this kind of case?
I would absolutely agree. There are a couple of things that I think this case brings to light. One is how wonderful for this man to find that he has a 1.4 centimeter lesion. I think this is a scenario that we likely will see more often in the coming years as we start understanding what role screening might have in a population that might be at risk for developing lung cancer. So on first glance, this gentleman should have an excellent prognosis with just one small lesion. The 3 millimeter lesion comes from probably a pathologist who really paid a lot of attention and sectioned an entire lobectomy carefully to find a tiny, probably not palpable lesion. So he ends up having T3N0, as Dr. Doble had mentioned. The problem is that this scenario is very unusual. The data that we have regarding adjuvant study is populated primarily by patients who have nodal disease, and I would consider this sort of a data-free zone. The studies that we have really don't address this gentleman. However, if we look at the new staging system and we look at survival curves, he does have a substantial risk of recurrence, and he may elect to move forward with chemotherapy. Again, this is a squamous lesion. You always worry that this gentleman has a propensity for developing other lesions. I don't think chemotherapy would keep him from developing a cancer that was destined to be. I mean, this would really be looking for recurrence. It may have a benefit for someone who has no other medical problems and his survival was felt would be 15, 20, 30 years. And then I think it would be very reasonable and it would be a very personal decision.
Dr. Suresh Ramalingam from the Winship Cancer Center, Emory University in Atlanta, Georgia.
So this is an area where we don't have a lot of clarity on. Clearly, we know that for patients who have node-positive disease or larger tumors, vis-a-vis more than 4 centimeters, there is a role for adjuvant chemotherapy. In this case, this patient's tumor, according to the new staging system, would be a stage 2 cancer, but a very small primary, and I presume this is node negative. So in a patient who is young and has a very good performance status and no other major medical comorbid illness, I would lean on the side of giving chemotherapy just as a preventative measure. Now, we know that this is a subgroup of patients that have a relatively better outcome compared to some of the other types of stage 2 patients. But having said that, given how notorious lung cancer is, and given that some of these patients were actually included in the clinical trials that evaluated the role of adjuvant chemotherapy, my position outside of a clinical trial would be to err on the side of treating this patient with chemo.
The histology itself, of it being squamous versus adeno, does that really affect your mindset about inclination toward or against adjuvant chemotherapy?
The difference in histology in terms of whether to treat or not treat a cancer is not something we routinely do. I am well aware of how, we all are aware of how adenocarcinomas tend to be more aggressive and develop distant metastasis very quickly versus the squames, which tend to be, in many instances, locally invasive and regional cancers. We use histology to select different kinds of treatment, but at this point, I don't think we have enough to say a patient with squamous with similar characteristics should not receive chemo versus a similar patient with adeno getting chemo. So to me, that is relevant, but it does not help me make a decision one way or the other.
Dr. Jonathan Goldman from Premier Oncology in Santa Monica, California.
I think adjuvant chemotherapy is a very special circumstance that you face as a medical oncologist because you hope to have the opportunity to cure a patient. You have to weigh against that the toxicity and also the uncertainty. You never know which patient you benefited and which you didn't. I do tend to think of a circumstance like this telling us something about the biology of the cells and that these cancer cells were able to spread, that there is maybe not too much of a difference between this and someone with higher lymph node involvement. And so my leaning is to treat a patient like this with chemotherapy, but be very clear with a patient that the data is not entirely clear and that we're doing our best to extrapolate.
Dr. Julie Bramer from the Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland.
Unfortunately, most of the adjuvant studies didn't include patients with this type of disease. So it's hard, how can we best use that data and extrapolate to this patient? And I think, again, it gets back to how quickly did this nodule come up, how aggressive is this tumor. If there's other satellite nodules, I do get nervous that there may be other nodules elsewhere that we just can't see again, but I can't tell that patient that they're going to benefit from adjuvant chemotherapy, but I think it would be worth a try. Again, if it's a very slow-growing tumor, if we have any history on that, then I may be less likely to recommend adjuvant chemotherapy, but if it's something that I have no history on, or if it's documented that it's relatively aggressive tumor, then I would certainly recommend at least trying the adjuvant chemotherapy. This comes up all the time. We just had another case like this in our tumor conference last week that only a little bit older patient, but had some multiple satellite lesions. Again, they were quite small, but we recommended at least considering adjuvant chemotherapy. And again, I would recommend cisplatin, and if that patient just couldn't tolerate cisplatin, then maybe backing off and not doing chemotherapy would be appropriate when we just don't know whether or not the chemotherapy is going to benefit.
Dr. Heather Wakely from Stanford University Cancer Center in Palo Alto, California.
With just the 1.4 centimeter squamous, the answer would be no, I really don't think there would be any role for adjuvant chemotherapy. With the satellite nodules, we don't know. With the old staging system that was in place for all of the adjuvant trials, that was obviously a stage 3B, and those weren't included. With the new staging system, it was technically a stage 3, but we don't have that type. The tumor with the satellite nodules haven't been in the adjuvant trials, so we don't really know that chemo makes a difference. The first thing I would do is obviously really work with the pathologist to make sure that this was truly a satellite and not something where you could see a little bridge going to it or some other direct connection. And if you could identify that, I would still say no. With it, it does raise the concern that either there's a second primary or that this is truly a satellite. If it's a second primary and they've got two little tiny primaries that are out, I would still say no. If it's truly a satellite, looks like it's exactly the same histology, it's absolutely not connected, then I would again tell the patient that go through the risks of chemotherapy and that from the benefit side, that there was a chance of benefit given that this tumor had already spread. I would probably quote in the 5 to 10% absolute survival benefit at 5 years, but really kind of pulling that out of the air because there's no strong data. And again, would go over it with the patient. And some patients, given that information, look at you like you're crazy for even bringing up chemotherapy if it's only a 5 to 10% difference and it's 3 months of chemo. And other people, of course, jump at anything that could offer any help. So it's going to be very dependent on that particular person.
Dr. Karen Reckamp from the City of Hope Cancer Center in Duarte, California.
I think that a satellite, whether it's microscopic or not, I think a satellite nodule shows us that there's more cancer and it has had the opportunity to spread. So I think in this case, I take it more like a stage 2 lung cancer and T3 lung cancer. In a good performance status patient without significant comorbidities, I would have a serious conversation about adjuvant chemotherapy, because I think that this portends to somebody who has potentially micrometastatic disease, and those are the patients we are trying to treat and trying to get rid of any of those cancer cells that might be lingering behind.
We hope that the program was helpful, and we'd again like to thank the folks from Longevity Foundation for their partnership on this program. Thank you.